hematologic disorders. Hematologic disorders present a varied clinical manifestations. Okay, usually the general symptoms may be like fatigue, fever, infections. These symptoms do not give an indication of an underlying hematologic abnormality or disorder. So they are like obscure in nature. You will know them only on blood picture examination, like that. So we'll see the diseases involving the red blood cells, the white blood cells, and the platelets. We know blood has a lot of components, mainly the RBC, the WBC, the platelets. So each component shows, if it shows either a decrease or an increase, correspondingly we get to see the diseases of hematologic abnormality. So we'll we know that the normal red blood cell count or the erythrocyte count is about 8 million cells per cubic millimeter. So either an increase or a decrease, it presents disorder or a disease of red blood cell, and along with that you see specific oral manifestations. So the general symptoms along with the systemic symptoms, you get to see the oral manifestations, and these oral manifestations make the patient present themselves to the dentist requiring treatment for that particular oral manifestations. So these oral manifestations have to be studied intensively with a blood picture examination, because just appearance of a glossitis or a painful tongue may not give an hematologic abnormality indication. So whenever the dentist sees such symptoms, and when he correlates it with the complete blood picture examination, then he will be able to detect the hematologic disorder underlying it. So we'll study the diseases involving the red blood cells, the white blood cells, and the platelets. We know hematopoiesis, the production of blood cells is naturally occurring where the blast cells or the erythroblasts or the myeloblast, they give rise to the erythrocytes. Erythrocytes are the active components. Blasts are the stem cells which produce the erythrocytes. Okay, so first we'll see the diseases of red blood cells. Red blood cells, the commonest disorder is the anemia. As we all know, we have seen a lot of people with paleness of the skin. That is nothing but because of anemia. Anemia is defined as reduction in number of circulating red blood cells. That is, the red blood cell count is decreased. Inevitably, the quantity of hemoglobin is decreased, and thereby the mean corpuscular volume of hemoglobin, mean corpuscular volume of blood is decreased. So basically anemia is a disorder affecting the red blood cells, right? Red blood cells, what are they? They have the oxygen carrying capacity. They are responsible for delivering the oxygen to the cells and tissues of the body, and thereby transporting the carbon dioxide to the lungs for deoxygenation process. Okay, so when anemia occurs, the oxygen carrying capacity of blood is decreased. So that corresponds to the paleness of the skin. And the clinical symptoms are also based on that same thing, that the oxygen carrying capacity of blood is decreased, right? So the clinical symptoms are fatigue, generalized pain, weakness, and dyspnea and exhaustion. Even if the individual walks for a few steps, he'll be suffering from breathlessness, shortness of breath, dyspnea, and extremely tired even on doing routine and very simple works which do not require much of effort. So because the hemoglobin carrying blood cells, that is the red blood cells, are reduced in number. Normally we require about 5 to 8 million cells per cubic mm. So anything less than that is definitely going to affect your system, body. So anemia, there are variety of causes causing anemia. That is, the etiology may be the chronic blood loss, either due to injury or in cases of menstruation. So these chronic blood loss, along with that you see increased production of increased destruction of red blood cells, and again the etiologic classification includes the deficiency of intake. that is the dietary intake is not sufficient, either the iron deficiency or the folic acid deficiency or the vitamin B12 deficiency. Inadequate absorption of nutrients is the other cause. So the individuals have some abnormality in their gastrointestinal system, which leads to inability to absorb the symptom, inability to absorb the vitamins or folic acid, even though the normal production is of the factor is present. So all these, there are a variety of classifications of anemia, and anemia has also been classified based on etiological classification and based on the size of the cells, that is the macrocytic anemia, where the size of the cells is little bit large, microcytic anemia where the size of cells is smaller, and the normocytic anemia where the size of cells is normal as that of seen routinely. So in the microcytic anemia, the mean corpuscular volume is decreased. In the normocytic anemia, the mean corpuscular volume is normal, but the hemoglobin content may be decreased. So we'll study few of the common anemias like the iron deficiency anemia and the vitamin B12 deficiency anemia or the pernicious anemia, and few of the syndromes are associated with it. Okay. So vitamin B12 deficiency anemia, also commonly known as the pernicious anemia. Pernicious anemia, it's also known by other names like Addisonian anemia and Bayerman anemia. So by pernicious anemia, the term pernicious anemia is given when the individual shows reduced capacity to absorb the vitamin B12. It is because of loss of intrinsic factor production in the stomach. So the stomach shows the loss of intrinsic factor production. So thereby gastric atrophy is noticed, and the vitamin B12, even though produced in normal quantity, it's just not absorbed, leading to the clinical manifestations. So pernicious anemia, it shows a triad of symptoms. There is a generalized body weakness. Along with that, patient complains of a sore, painful tongue and the numbness in extremities, tingling sensation or paresthetic sensations or numbing sensation of the extremities. So the general symptoms of anemia, as I have already told, the oxygen carrying capacity is decreased. So the patient complains of generalized symptoms like easy fatigability, tiredness and dizziness, nausea, headache, mental confusion. The patient will be just unable to concentrate. So pernicious anemia presents generalized systemic symptoms along with the neurologic manifestations. And as with all the cases, the anemia literally has been attributed to the yellowish pallor of the skin, the conjunctiva and the mucous membrane, oral mucous membranes also. So this yellowish tinge is attributed to the fact that the hemoglobin content is decreased. So generalized symptoms, neurologic symptoms, along with that the characteristic yellowish tinge of the skin. So the triad of symptoms is, of pernicious anemia is characteristic. So these are the general symptoms. So we will specifically see what are the oral manifestations of pernicious anemia. So whenever you see a oral cavity, how to suspect a disease or how do you make out the case of pernicious anemia. So first we'll see the general symptoms. The general symptoms are like, as I have already said, the paleness of the skin affecting the skin, the mucous membrane and the conjunctiva. Along with that, general symptoms like shortness of breath, dyspnea, tiredness, and neurologic symptoms include the fatigue, dizziness, mental confusion, inability to concentrate. Along with that, because the oxygen carrying capacity of blood is decreased, so the heart it tries to increase the cardiac output to compensate for the reduced oxygen. So thereby we'll see cardiac murmurs, the palpitations and increased heart rate. Along with that, splenomegaly is commonly seen. So these are the general symptoms. Now if we see the oral manifestations, characteristic appearances of the tongue. The tongue shows the tongue is little bit enlarged, it's highly inflamed, very red, edematous, and it shows the characteristic beefy red color. So this glossitis is very painful and patient sometimes presents to you with a burning sensation burning, itching and tingling sensation of the tongue. Along with that, you see glossodynia and glossopyrosis, that is inability to swallow or speak. So along with this generalized inflammation, there is loss of filiform papillae initially. So this atrophy of filiform papillae initially it gives the appearance of what is called as Hunter's tongue glossitis or Muller's glossitis. So this atrophy of filiform papillae then progresses to atrophy of fungiform papillae also. Inevitably, the tongue appears smooth or bald in appearance. This smoothness has been compared to the bald tongue of sandwich, that is in a pellagra niacin deficiency. At that cases also you see a very smooth tongue without any papillae. So initially you see glossitis, which progresses to the atrophy of all the papillae. So the basic disorder here is the loss of intrinsic factor production in the stomach, which leads to inability to absorb the vitamin B12. So intrinsic factor has been lost. So that's that we see features of achlorhydria, that is the reduction in the gastric secretions in the stomach. If we see the gastric secretions when compared with normal person, about 10 to 20% gastric secretions are decreased. So the laboratory findings characteristic of pernicious anemia are the reduced red blood cell counts, very low red blood cell counts are seen. Along with the red blood cell count, the leukocyte counts is also decreased, and even if the RBC whatever are present, the fewer in number, they show changes in sizes and shapes, that is nothing but the poikilocytosis. So the red blood cells show changes in shape. Along with that, hemoglobin content is reduced, and we see atrophy of the gastric mucosa, so the gastric secretions are also decreased. So this complete blood picture usually gives the indication that RBC count is decreased. So that is the diagnostic test for it. Along with that, if we see the bone marrow biopsy, the bone marrow is appearing hypercellular, and the erythroid precursors are very large. So the precursors are not giving the required quantity of erythrocytes. So the erythroid precursors are large. They show a very large nucleus with sometimes clumping of the chromatin material at one side. That gives the appearance of the checkerboard appearance of the nucleus. The nucleus is large, and the nucleoli or the chromatin material, it's just condensed to at few points. So that is giving this checkerboard appearance, characteristic of this pernicious anemia. So the complete blood picture is giving this view. So how do you treat the case of pernicious anemia? So the general symptoms include the vitamin B12 deficiency. So you give cyanocobalamin or methemoglobin injections to just normalize the level of vitamin B12. As soon as you just start treating the case, the pallor of the skin just changes back to the normal state. So we have seen in the clinical pictures of the oral manifestation how the tongue is very beefy red in color with the appearance of glossitis, and the yellowish color of the generalized body skin or mucous membrane, it just changes back to the normal level. So that's about the pernicious anemia. So the other commonest anemia is the aplastic anemia. Actually, aplastic anemia, it's also known as pancytopenia because it is characterized by a bone marrow failure syndrome. Here in aplastic anemia, you see deficiency of all the cells, that is the red blood cells, the white blood cells and the platelets. So it is characterized by a lack of bone marrow activity. So aplastic anemia, again, it's of two types, that is the primary aplastic anemia and the secondary aplastic anemia. Primary aplastic anemia, it's of unknown etiology, it's occurring in children and the etiology is unknown. Whereas the secondary aplastic anemia, it's seen in the middle-aged individuals or young adults, and it has been attributed to ingestion of few of the drugs like the benzene, busulfan, methoxamine. So these drugs, they are like self-medicated. Patients take self-medication, or even when they are under prescription of these drugs, the blood picture shows the presence of this aplastic anemia. Usually, this disorder or aplastic anemia has been seen in healthcare professionals, that is the nurses, physicians, or the pharmacists, because they are like these drugs are freely available to them. So they take self-medication, and invariably you see the reduction in all the blood cells. So the clinical symptoms include the appearance of anemia along with the leukopenia and the thrombocytopenia. As we know, the general symptoms of anemia includes a pallor of the skin along with generalized weakness, malaise, tiredness, fever. So that is about the anemia. When you see the leukopenia, again it presents a picture of hemorrhages of the skin or mucous membrane. And when you see the thrombocytopenia case, you see the appearance of petechiae or purpura, purplish discoloration, or the appearance of purpuric spots on the skin or mucous membrane, that is the petechiae. So, and neurologic manifestations includes the numbness or the tingling of extremities. So that is because of degeneration of the few of the peripheral nerves occurs. So that gives the neurologic manifestations. So if we can see the general symptoms of the aplastic anemia, we can see the patient has lethargy, that is, he is very weak, extremely tired, he is fatigued, he is anorexic, that is, there appears to be eating disorder, and some form of endocrine disturbance is seen. Along with that, bleeding disorders and increased appearance of pruritus or petechiae and neuromuscular disturbances are seen. So here in the clinical picture, you can just see the petechia are nothing but purplic spots or hematomas seen. In the oral cavity, it is seen in the lips, tongue, or the buccal mucosa. And because of leukopenia, generalized edema or inflammation is seen. Along with that, neutropenia, there is a decrease in number of neutrophils is seen. So there is no inflammatory response for any sort of infection occurring to the body. So even if whenever the foreign body enters the body, our body has a system to generate inflammatory response by release of some mediators, polymorphonuclear leukocytes, like that. In cases of aplastic anemia, the patient doesn't have that capacity to just generate the inflammatory mediators or polymorphonuclear leukocytes. So there is lack of inflammatory response. The inflammation just progresses. The infection just progresses widely, spreading to the other systems. So clinical appearance is very severe like that. The laboratory findings are nothing but the appearance of more of or reduction of erythrocytes, red blood cells, reduction of leukocytes, then the reduction of even the platelets. So the clotting time may remain normal, but the number of erythrocytes are reduced, right? So the bleeding time is prolonged. So the blood picture here, you can see it presents a reduction of all of the cells. So very few cells are seen per cubic millimeter. The treatment of this includes the supportive therapy. The supportive therapy includes the treatment of whatever infection you are seeing in the oral cavity, whatever inflammation you are seeing in the oral cavity, just treat that. Normally, the oral manifestations for aplastic anemia, again, it includes the symptoms of glossitis as seen in the pernicious anemia and the gingival hyperplasia. So any infection, actually the inflammatory mediators or whatever the foreign bodies are, they enter the gingiva through that gingival sulcus. So the whatever infection is there, simple gingivitis, because of lack of inflammatory response, it will be aggravated to gingival hyperplasia covering all the teeth. So it presents more severe manifestations. So treatment of underlying infections has to be carried out. Supportive therapy in severe cases, the ultimate treatment will be the blood transfusion. So the etiology, whatever, if you identify as we have seen, the secondary aplastic anemia, it's because of the drugs, right? Benzene or whatever drug is there, sulfan drug. So if you just remove the etiology or the drug which is causing the disease, automatically you see the regression of the clinical symptoms and regression of this aplastic anemia. So the other common and the most severe form affecting the children, especially the young children or the infants, is the thalassemia. Thalassemia, it's also known as Cooley's anemia or Mediterranean anemia. Here actually the normal RBC, whichever are spherical in shape, they are distorted. This distortion is because of the abnormal hemoglobin formed in the blood. So thalassemia, it's actually a genetically determined disorder of hemoglobin synthesis. So the hemoglobin, normal adult hemoglobin, it shows a heme protein which is bound to heme ionic component, that is the heme protein, which is bound to the other component, that is the globin part. So these two are bounded. The globin part, it has 2 alpha chains and 2 beta chains normally. So whenever there is a defect in the alpha chain or the production of beta chains, there is alteration of the hemoglobin complex form finally. So ultimately the red blood cell is malformed, and thereby the whatever function it's performing, it's just function of oxygen carrying capacity, it's just decreased, and you see the clinical manifestation. There are 2 forms of thalassemia. There is the thalassemia minor and the thalassemia major. Thalassemia minor, it's basically, it shows defect in the alpha chain, that is the number of alpha chains are reduced. So it's seen in heterozygote individuals, so the case is not that severe. Whereas thalassemia minor, it is seen in homozygous individuals, and it is due to the deficiency of beta globin chains. So this thalassemia major form, it presents more severe clinical manifestations, and ultimately death results in the individuals of thalassemia major. So that is genetically determined disorder, so it is transmitted as a recessive trait to the individuals. So the onset of thalassemia, it's seen in the first 2 years of life. So before even the individual is of 6 months of age, you see the clinical symptoms start appearing. So it is a inherited trait, right? So if for autosomal recessive inheritance, so if 4 children are there, so compulsory 2 children will be definitely affected by that disease. So the symptoms of anemia, as characteristically we have seen the yellowish pallor of the skin is present, along with that fatigue, weakness, and splenomegaly and hepatomegaly may be present. So these are the general manifestations. Initially you notice the fever, infections, malaise, lymphadenopathy, lymph nodes may also be enlarged. So along with that, splenomegaly and hepatomegaly. When you see this specifically the oral cavity, when you specifically see the oral cavity presents the depression of the nasal bridge, that gives rise to the rodent facies appearance, prominence of cheekbones along with the depression of nasal bridge, that gives rise to the rodent facies appearance. And when you see the oral cavity, there is prominence of the premaxilla. The premaxilla appears to be protruded. The clinical manifestations of thalassemia, we have seen that the child is extremely weak, fatigued. Along with that, the prominence of cheekbones and the depressed nasal bridge, that has been given the term as rodent facies. When you see radiographic appearance, it has a very varied manifestations of because the medulla of bone, it becomes radiodense, whereas the outer cortices, they are like little bit thick in color. So if we see a rib of a patient affected by thalassemia, the inner medulla, it's radiodense, and the cortex, it's thick. So it gives the appearance of rib within a rib appearance. So that's with the rib. When you see the skull of the patient, that is the diplo, that is the central medulla of the skull, it's radiodense. Then when you see the thick cortex or the outer and inner plates of the skull, they appear thin and they show increased trabeculation. The trabecula appears to be just radiating from the outer plate to the inner plate. That gives this crew cut or hair on end appearance of the skull bones. So along with that, as we have seen, the medulla is becoming radiodense there, so there is pneumatization of even the sinuses of sinuses of face. The ethmoidal sinus, it's spayed because it doesn't have any marrow, the ethmoidal sinus. Okay, and when we see the intraoral periapical radiograph of a thalassemic individual, both the maxilla and the mandible, they show the increased trabeculation. So the few areas show normal appearance, few show increased trabeculation. That gives to this salt and pepper effect appearance of the maxilla and mandible. So that's about the radiologic features. So we have seen the clinical features of thalassemic child and the radiographic appearance. So when we see conduct a complete blood picture, then we see that the individual has a reduction in red blood cells, that is the anemia is of hypochromic microcytic type. So all the cells are smaller in size, they are reduced in size. They show anisocytosis, poikilocytosis. And the cells, the red blood cells, they show the typical appearance that the nucleus or the chromatin material is just concentrated at one place, giving the appearance of this safety pin cells. The erythroid cells, whatever are present, erythrocytes, they are giving that characteristic appearance of the safety pin cells. Both the WBC count is elevated, just showing that the presence of lot of infections in the thalassemic child. And the bone marrow shows cellular hyperplasia. There is an increase in precursors of the erythroid or the WBC, whatever. So there is increase in erythroid precursors. It shows a hyperplastic appearance, bone marrow. So that's about the thalassemia. Now, whenever the clinical symptoms are of anemia, appearance of jaundice, hepatomegaly, splenomegaly, all this gives initially the picture of iron deficiency anemia. So the physician just sees that it's iron deficiency and goes on giving the iron supplements, because it's the clinical appearance is the manifestations of iron deficiency. So, but due to this, it leads to overload of iron in the body. So iron gets deposited in lungs, kidneys, spleen, so a lot of places. So iron overload is the most commonest complication seen in thalassemic individuals. So it mistakenly diagnosed as iron deficiency anemia, thalassemia is diagnosed like that. So few of the cases, blood transfusions are given. These blood transfusions provide only a temporary remissions, because ultimately it is a genetic defect, right? So the hemoglobin, whatever the alpha chains or the beta chains, whatever are deficient, you are not doing anything to that. You are just replacing the blood, so it's just a temporary relief. So ultimately the defect of alpha chain synthesis continues like that, and the patient just suffers a lot, and a lot of childs are affected by thalassemia major. They just see the death, because this thalassemia is affecting a very young children at the 6 months of age, like that. So the chances of survival are very less in cases of thalassemia major. Yeah, bone marrow transplantation, it has shown very significantly positive results. Along with that, transfusions also may have to be carried out at regular intervals. But bone marrow transplantation is the ultimate treatment for it. And the next commonest blood disorder affecting the red blood cells is the sickle cell anemia. As we know, sickle cell anemia, has been shown a racial predilection, because it occurs more often in the American blacks. About 65% of population, American black population, it shows this sickle cell anemia. It is basically a hemolytic anemia, showing there is destruction of the red blood cells, increased destruction of red blood cells. And this sickle cell anemia, it's transmitted as a autosomal dominant inherited trait. So what happens? We see that normal adult hemoglobin is present. It has the iron heme component, the globin component. But here in sickle cell anemia, the shape of the red blood cells is just changed to the sickle shape or the S shape, because of loss of fibrin strands in that. So that gives the appearance of the complete hemoglobin. The adult hemoglobin HbA is changed to hemoglobin sickle, that is the HbS. It is basically because of replacement of glutamine in the position 6 by valine amino acid. Amino acid glutamine is just replaced by valine, so that the adult hemoglobin is changed to the sickle hemoglobin. So the clinical features, it's sickle cell anemia. It most commonly affects the individuals before 30 years of age. So the young adults are more commonly affected, the middle-aged individuals or the younger adults. Then the clinical symptoms of anemia. The hemoglobin, the red blood cell shape itself is changed. So the oxygen carrying capacity is decreased, and there is decreased viscosity in the blood. So the blood flow is decreased. So increased tissue perfusion or anoxia is seen. So the patient is very weak. Symptoms of anemia, there is a shortness of breath, easy fatigability is seen. Along with that, you can see the pain or stiffness in the joints. And symptoms of anorexia, nausea, vomiting may be seen. Along with that, because the oxygen carrying capacity is decreased, the heart tries to increase the cardiac output to compensate for that. And then you can see appearance of murmurs or increased heart rate, systolic murmur, and the heart may be ultimately enlarged cardiomegaly. So all these are to counteract the effects of tissue tissue perfusion, that is anoxic effects. So here you can see the normal red blood cells, how they maintain the blood flow, blood viscosity. That is not possible in case of sickle cell hemoglobin, sickled cells. So this sickling leads to decrease in blood viscosity, tissue perfusion, ultimately anoxia. So when you see the radiographic picture of individual affected by sickle cell anemia, you can see there is generalized osteoporosis of bone, that is there is a few areas show radiodensity and few show radiopacity. The osteate formation is seen because of stimulation of the red blood cells or the bone marrow. And few areas you can see there is just when you see the jaw bones, there is a loss of normal trabeculation, giving an appearance of ground glass appearance for the radiograph. So, and the characteristic appearance of a radiodensity in the medulla with the thickening of the cortices, that is nothing but the hair on end appearance as seen in the thalassemic individuals. So when we see the skull, the inner component, that is the medulla, is radiodense, and the outer component, both the outer plates of the skull bone, they are thickened, and the trabecula appears to be just radiating from the outer plate to the inner plate. That is the hair on end appearance. And the generalized osteoporosis is because of activation of the osteoblasts, the osteoclast, and just that accounts for that loss of trabeculation and even the ground glass appearance. And when you see the diagnostic picture, laboratory picture of the blood, complete blood picture, it shows that red blood cell count is definitely below normal levels. And the typical sickling of the red blood cells, here you can see in the clinical picture, the normal RBC are bound to be little bit spherical in shape, but the sickle RBC are elongated in shape. That is because the hemoglobin is altered, the fibrin strands are altered, and they just constrict the red blood cell to this shape. So the sickle cell hemoglobin, sickle cell anemia, the individuals just, there is no treatment for that disease, there is no hormone replacement or genetic replacement, anything is not possible, because it's like an inherited trait and seen in a few of the American blacks population only. They just remain with that disease forever, and they just go on transmitting that disease as autosomal dominant trait to the individuals, and it is seen in just families only, and restricted to the American blacks population now. And so you cannot just do anything for that sickle cells. Yeah, you can give symptomatic treatment, like the symptoms of anemia, they can be just alleviated, or relief can be provided by just increasing the oxygen consumption, or providing blood transfusions as and when required. definitive therapy is not there for sickle cell anemia. Then other commonest blood disorder which affects the children and which has specific characteristic oral manifestations is this erythroblastosis fetalis. Erythroblastosis fetalis is actually a congenital hemolytic anemia that is seen in the individuals or infants when they are at the time of birth. It is due to RH incompatibility. What is RH factor? RH factor, as we know, it's a factor present in the blood. It was discovered by Wiener and Landsteiner. So erythroblastosis fetalis, it is due to RH incompatibility, right? So we have studied that RH factor. It's a factor derived from the blood. It's a blood factor. It is basically derived from rhesus monkey. So whenever this RH factor it's just injected into humans or rabbit, you get an anti-serum. So that anti-serum it shows it's that whether the individual is RH positive or RH negative. So this erythroblastosis fetalis is it's a disease. It's arising because of development of antibodies to the RH factor. So not all population is RH positive. Half of the population is like RH positive and about 30 to 40% population is RH negative. So in cases, suppose a case where a father is RH positive, he marries a woman who is RH negative, and when they conceive a child, okay, so here you can see in the picture. So the mother is RH negative, she is conceiving a child. So she married a RH positive person. So the child is RH positive. So now, because of the RH positive fetus, antigens are developed in the body. These antigens, through transplacental transfer, they enter the maternal blood. From the fetal blood, the RH antigens are transferred to the maternal blood. So once they enter into the maternal blood, the mother develops immunization to the RH factor. So anti-RH antibodies are developed. So that way, by the time the RH antibodies are produced, the first fetus have been just delivered. The child has been delivered. So he is not affected. But when the RH negative mother, the immunized RH negative mother, again she conceives for the second time. So this time she already has the antibodies in her blood. Okay, RH antibodies in the blood, and this time again the fetus is RH positive fetus, and whatever be the fetus, the RH antibodies are present in the maternal blood. They just attack the fetus. They just the antibodies just enter the fetal blood and thereby inevitably leading to the expulsion or death of the fetus. So erythroblastosis fetalis, the child is just stillborn. He is not born like that. He is not born alive. So that now the erythroblastosis fetalis cases, previously in the history, a lot of miscarriages or death in infants used to occur due to this disease, but now screening for this erythroblastosis RH positive factor is done, and blood transfusions carried out safely lead to the individual the antibodies not being transferred to the child. So the clinical features of RH positive, that is erythroblastosis fetalis, the individual, the child affected by erythroblastosis fetalis, he shows the presence of anemia with jaundice. There is increased serum bilirubin content invariably because of the anemia. Along with that, there is increased production of destruction of the red blood cells, that is the erythropoiesis is seen, and generalized edema of the body is seen. That is nothing but the fetal hydrops phenomena. And when you see the oral cavity, general symptoms are the symptoms which we see normally, that is the anemia, jaundice and all. So when you see the oral cavity, specifically the teeth which have been developing at the time when this RH positive phenomena is occurring, the antibodies are being transferred from the mother to the child. The teeth which have been developing during that process are affected, and they show deposition of the blood pigment in the teeth, in the dentine, in the enamel. And these, whatever pigment is deposited, is intrinsic in nature. So you see blue-green deposition. Blue-green deposition is characteristic of the erythroblastosis fetalis. And the teeth which are affected are the incisal edges of the maxillary anterior teeth and the middle portion of the deciduous cuspid and molar. So this teeth have the characteristic deposition is called as the RH hump phenomena. RH hump. See, and there is a hypoplasia of enamel surface, which is usually seen. The as I have told, there is the increased destruction of red blood cells is seen. So RBC count is just reduced in number, red blood cell count, and the serum bilirubin is increased. So the icterus index, which is the jaundice diagnostic test, that is very high. It has to be below 50 like that, and here icterus index is around 100. So how do you prevent a case of erythroblastosis fetalis? It's prevented by screening of maternal screening at the time before the birth of the child, and to give anti-D gamma globulin to the mother, so that the immunization just fades away. She becomes non-immunized. From immunized, she becomes non-immunized, and thus the antibodies are not transferred to the child. And blood transfusions, they definitely help in removing the antibodies whatever are deposited, and thus prevent the child. Only the second child is basically affected by this disease, erythroblastosis fetalis. Next, we have seen the deficiency of anemia due to vitamin B12 and due to change in the form or shape of the cell or the inherited anemias. We are now seeing the commonest anemia, which is affecting about 60 to 70% of the general population. That is the iron deficiency anemia. Almost everyone has some form of iron deficiency. So the normal adult male, he requires 1000 micrograms of iron intake daily, and this intake in cases of females, it usually doubles up when in conditions of pregnancy or chronic blood loss due to menstruation. Adult male, he usually just excretes about 1 microgram of iron per day, whereas in females about 2 microgram per day of iron is excreted. Along with that, females have increased requirements for the iron because of the childbearing age or because of the chronic blood loss due to menstruation. So the etiology for iron deficiency anemia is nothing but the chronic blood loss or the inadequate dietary intake or the faulty iron absorption, and the increased requirements of iron, that is nothing but the pregnancy and the childbearing age. And the iron deficiency anemia has also been associated with other features, other characteristic features, which give them the name of the Plummer-Vinson syndrome or the Patterson-Kelly-Brown syndrome. Anemia is nothing but the reduction in number of red blood cells. As we can see in the picture, normally about 8 to 10 million, 5 to 8 million cells per cubic millimeter are present, and they are just decreased or reduced in number, the red blood cell counts. And the iron deficiency anemia specifically, it appears about middle-aged individuals. That is about 4th to 5th decade of life, with an increased predilation for females, because females are the ones, they show chronic blood loss and increased requirements of iron. And the presenting features for iron deficiency anemia is nothing but the appearance of anemia. There is the generalized pallor of the skin. Along with that, you can see tiredness, easy fatigability, dyspnea, shortness of breath or exertion, or even on slight physical exercise, the individual suffers just the shortness of breath. Along with that, the characteristic lemon-tinted pallor of the skin, the oral mucous membrane, and sometimes even the conjunctiva shows because of the appearance of jaundice. And when you see the oral cavity, especially the oral cavity, whatever be the disease affecting the red blood cells, it shows the inflammation of the oral mucosa. That constitutes for the burning sensation or the stinging sensation of the oral mucosa. Along with that, glossitis. The glossitis, it's like extremely painful. The tongue is enlarged, it's edematous. It is very painful. So here the glossitis, it's accompanied by the atrophy of the papillae. That is nothing but the filiform papillae and fungiform papillae are atrophied, and they give the appearance of a ball tongue like that. And then along with the iron deficiency anemia, the characteristic features of iron deficiency anemia, if you see spoon shaped nails, that is Coelinecia. So iron deficiency anemia along with presence of spoon shaped nails and the esophageal strictures, that is the esophagus just gets narrowed, that is the webbed appearance of the esophagus. These three contribute to the Plummer-Vinson syndrome. It's the most severe form of the iron deficiency anemia actually. So the clinical picture or the laboratory picture of iron deficiency anemia is nothing but the red blood cell counts are like moderate in number, like 3 lakh to 4 lakh cells per cubic millimeter. Along with that, the serum iron and ferritin are decreased. Very low serum iron is present. So because of deficiency of iron, we know that iron is a major component of the hemoglobin molecule, that heme protein, heme whatever is there, that is nothing but the iron. Ferritin molecule which bounds to the heme. So it has a lot of effects on the oral cavity and the generalized body system also. So the treatment for iron deficiency anemia is nothing but iron supplements, or in case of pregnancy and all, iron injections may sometimes have to be given. So to prevent dyspnea, basically to prevent anoxia of the tissues, to prevent hypoxia of the tissues, and just to maintain the normal metabolism, to relieve the pallor, to relieve the dyspnea, just iron supplements or iron injections, ferritin in tablets supplements have to be given regularly. And in cases of increased requirements, when anticipated, every individual, especially females, should have to be put on iron supplements. So to prevent the development of the iron deficiency in pregnancy especially. So next we can see the increased production of red blood cells. Till now we have been seeing the diseases which are affecting the red blood cells, which should decrease production of red blood cells, whatever form of anemia. So polycythemia is the one which shows increased production of red blood cells. So there are three types of polycythemia. There is the relative polycythemia vera, in which the increase in red blood cells is not an absolute one, it's a relative increase in red blood cells. As in cases of loss of body fluids. So whenever there is excessive loss of body fluids because of vomiting, anorexia or diarrhea, in that cases the red blood cells, they appear to be increased in number. That is nothing but the relative increase in red blood cell count because of loss of body fluids. Then the absolute polycythemia, it's due to increase in the red blood cell count, which is absolute. There is true increase in the number of red blood cell counts. Then the other polycythemia is nothing but the polycythemia vera rubra. It's a secondary polycythemia. It's also known as Osler's disease. It's actually a pan-hyperplasia. It shows the increase in red blood cell counts. Along with the increase in red blood cell count, there is increase of the WBC and the platelets also. That's why it's also known as a neoplastic bone marrow disorder, because here the bone marrow is shows hyperplasia and there is increase in almost all the cells. The total blood volume is also increased. So this is an absolute increase in red blood cells. So the clinical manifestations include the generalized symptoms, that is nothing but the headache, dizziness, nausea, vomiting, diarrhea, and mental confusion or inability to concentrate, tinnitus or visual disturbance, problems with the hearing, and symptoms of anemia are seen, that are nothing but the skin appears flushed and engorged because of the capillary presence of the increased red blood cells and the presence of capillary blood. The skin, it's reddened like that, and the digits appear to be cyanotic or bluish in color. And you can see the clinical pictures there where there is a pallor of the skin, the is seen. The pinkish one is nothing but the polycythemia one, the reddened skin appearance. The digits also, they show very much increased RBC production, right? So the digits appear to be cyanotic because of accumulation of the whatever the deoxygenated blood is present. And when coming to the oral cavity, the oral cavity shows appearance of the same as seen on that of skin, that is the deep purplish pigmentation or the deep purplish appearance of the oral mucous membrane. Along with that, the gingiva, it appears to be enlarged and swollen owing to the increase in WBC, the increase in platelets. They show the appearance of petechia. Petechia nothing but purplish spots on the mucous membrane at the junction of the hard and soft palate. More commonly they are seen. So the oral mucous membrane shows deep purplish appearance along with the swollen edematous and inflamed red in color appearance. Along with that, the appearance of petechia, hemorrhages, gingivitis is more common here. So when you see a peripheral blood smear of a case with polycythemia, so it shows that the RBC is elevated, along with that lymphocytes are also elevated. There is a leukocytosis is seen, and the hemoglobin content is increased, absolute increase in hemoglobin content is seen. Along with that, the platelets are increased. There is nothing but the pan-hyperplasia. Celiac sprue. Celiac sprue, actually it is a disease of malabsorption. It has nothing to do with the diseases of blood cells. It's also known as disease of G-Herter disease. So celiac sprue, it's actually a chronic disease. It's affecting the intestines. There is malabsorption of ingested fat. Whatever dietary intake you are taking, the fat is not absorbed. That leads to excretion of fat. That is nothing but the steatorrhea. So it's a disorder affecting the intestines, right? So you see the symptoms of abdominal pain, deficiency of absorption of iron, defective absorption, then the brownish pigmentation of the skin. Then when coming to the oral cavity, you see the appearance of enlarged tongue. There is an inflamed edematous tongue. Along with that, atrophy of filiform papillae. It's basically the dietary intake is there, and there is a defect in absorption, malabsorption syndrome, celiac sprue is. So you have to treat it with administration of vitamin B and folic acid, and to relieve the symptoms of abdominal pain or nausea, dizziness, like that. Okay, so celiac sprue, it's not a disease of WBC, it's just a malabsorption syndrome. More commonly with the clinical appearance of glossitis, which is very severe here. Characteristic brown pigmentation of skin leads to this diagnosis of the celiac sprue.